In any tumor in the brain, early diagnosis and early intervention has the best chance of causing a remission. And in spite of all the best treatment, surgery, radiation, chemotherapy, the survival is quite low.
So, which are the headaches that we should be worried about and which are the headaches are benign?
So there's something called red flag headaches. So that's how we differentiate between headaches which are benign and headaches which need attention. So when the tumor is small, there are no symptoms. But the tumor grows only when it reaches a certain critical size.
Then the
symptoms start manifesting.
Hi, Dr. AB.
Hello again.
We talked a lot about, primary prevention and we tapped into your expertise. And I'm sure audience would have learned a lot from the previous episode.
I really hope so.
They will, for sure. But in this episode, I really want to dive deep into your bread and butter. You are a experienced neurosurgeon. 20 years of experience is not a joke. And I want to pick on your expertise and experience on general patient scenarios.
Sure.
So the first patient that I'm going to present to you is my very good friend. And he is in US, similar to me. We struggle together. And then now we are in good positions. He's a gastroenterologist. He is a physician as well. He started having headaches. He is 39-year-old. He called me. I said, okay, don't worry about it. Headache, don't take Tylenol. Sleep well. I said, don't look at your phone. Sleep well. So, and then, 2-3 days later, he said, dude, I don't think this headache is going away. And he started having signs of intracranial pressure, including nausea and vomiting during his procedure.
Boy.
While he is a doctor. As a doctor, he started vomiting. And he thought he ate something bad. And then I said, no, something is wrong. So he got an MRI of the brain. Because he's a doctor, he was able to expedite his MRI. And the bad thing that we were thinking about came out to be true, that he has a brain tumor. And the brain tumor turned out to be the most common brain tumor that we usually see, glioblastoma multiforme, GBM. And we got devastated and, we got the best brain surgeon and everybody, oncologist, John Hopkins and all those things. It turns out to be that it has spread and the prognosis is very poor. I'm getting very emotional even when I'm talking about this. But maybe as a learning experience, why is this happening? Why is brain tumors are getting increasingly common more than before, at least in my experience?
I don't know about the exact prevalence incidence of brain tumors in India because we don't have records again. Data is missing, but one thing is definitely awareness is increasing. So people are probably detecting brain tumors earlier and MRIs are becoming more easily available. Especially in India, MRIs are easy to get and not expensive like the US. So I think we are diagnosing brain tumors more often.
I see.
The unfortunate thing about almost every brain tumor is we don't know the etiology. Etiology is cause. I'm just saying it for the lay people because etiology means why did something happen. So for example, in lung cancer, we know smoking is an etiology of lung cancer or air pollution or exposure to asbestos. But in brain tumors, we don't have that. We don't know why. Many theories exist. Is it a virus? Is it some injury? Nobody really knows the answer. It's not been conclusively proven. But one thing is for sure that in any tumor in the brain, early diagnosis and early intervention has the best chance of causing a remission. And in terms of brain tumors, we really are speaking about two broad categories of tumors which arise in the brain. One are called primary brain tumors, other are called secondary brain tumors. So primary brain tumors are tumors that arise from a cell which is within the brain. And secondary brain tumors are tumors which spread from other parts of the body and go to the brain. So for example, I'm sure in your practice you have patients with cancer of the pancreas or colon.
Correct.
And they may spread to the brain.
Correct.
So those are secondary tumors. Primary tumors are typically gliomas. So gliomas comes from the word glia. in the brain, we have neurons, and then we have supporting cells called glial cells, astrocytes, oligodendrocytes, microglia. So tumors usually arise from these supporting cells, not from the neurons themselves.
So neurons are like my fingers, and
Yes.
supporting cells is a palm thing.
It's around that.
Around the fingers.
Yeah. So they do various activities of supporting the functioning of the neurons, and the tumors arise from these glial cells. Now, unfortunately, a lot of these tumors are picked up for the first time when they are very malignant. And the belief is that a lot of these grade 4 tumors or glioblastoma multiforme arise de novo. Means they start as grade 4 tumors. It's not that they progress from grade 1 to 2 to 3 to 4. So the time available to catch these tumors early is very limited.
Oh, I mean, that's the pathophysiology of the disease.
Yes. So in the WHO classification, which is modified every few years, we grade gliomas into grade 1, grade 2, grade 3 and grade 4 based on their behavior and their biology. In today's day and age, we are grading tumors based on certain markers. So there's a very important marker called IDH1, which is an important marker to test the behavior of tumors. And we look for certain genetic deletions to see if the tumor is sensitive to chemotherapy or not. But amongst the grade 4 tumors, which is most commonly glioblastoma, the prognosis is quite dismal. And in spite of all the best treatment, surgery, radiation, chemotherapy, the survival is quite low.
Quite low. So, based on my friend's experience, I just wanted to create a community health education in terms of, hey, yes, the initial symptom was headache.
Yeah.
Okay. So, if I say that, then I'll be like a Dr. Google. You go and
Headache
type
is such a common symptom that many people have, and most headaches are benign.
Most headaches are benign. If you type headache in Google, it's brain cancer. That's what it is.
Yeah.
So, which are the headaches that we should be worried about, and which are the headaches that are benign?
So there's something called red flag headaches. So that's how we differentiate between headaches which are benign and headaches which need attention. So red flags are if you have a new onset type of headache, not something you had in the past, and it is not triggered by some stressor. So for example, lack of sleep or stress or whatever, exercise, these kinds of things can typically trigger headaches in people, and these are headaches that are part of day-to-day life. We often get headaches and we take a pill and we're okay. So those are benign headaches. But if you get a new onset headache, which you never had in the past before, something different, and it is progressive. Like I said in the earlier discussion which we had on stroke, where strokes are happening in a few minutes to seconds, tumors are more progressive. They're increasing because the tumor is growing. And then the other important thing is you get early morning vomiting and blurring of vision. Those are signs of raised intracranial pressure. So these are the red flags that one should be aware of. In other red flags that should be taken into account is if the tumor is arising in a particular brain area, then it will cause dysfunction of that area. But sometimes it may arise in a relatively silent place where there are no symptoms related to that area. So for example, the right frontal lobe, for example, it does not give rise to any obvious clinical symptoms sometimes. But if it was arising in the left frontal lobe, where the speech area is, then the person would have dysphasia, which is an abnormality in the speech.
So these are all symptoms localization.
So localization of symptoms, but the sad thing about glioblastomas is we often diagnose them when they're quite large. So when the tumor is small, there are no symptoms. But the tumor grows only when it reaches a certain critical size.
Then the
symptoms start manifesting.
So let's say, in your experience, you have operated on a lot of GBM,
yes.
right? Can you tell us the procedure?
So the procedure first, of course, is to do an MRI. And nowadays, like I mentioned earlier, we do resting fMRI, particularly if the tumor is in an eloquent area, like near the area of the brain that controls movement or speech or sensation or vision or hearing. Then we want to understand the networks around the tumor. Then we plan a trajectory. Today's day and age, we use a lot of advanced systems to ensure that the outcome from surgery is good. Why do we want a good outcome from surgery? There are two things we need from surgery. We need to remove as much of the tumor as is safely possible. And we want to preserve the patient's function. Because for the patient to undergo adjuvant therapy like radiation and chemotherapy, the patient should have preserved function. I can't expect a patient who's hemiplegic to go for radiation therapy.
Who cannot move his arm and leg to go for all these advanced treatments.
Or it may worsen the edema in the brain also. So the whole goal is to do targeted, highly precise, extirpative surgery to achieve maximum resection as safely as possible. How do we achieve maximum resection? We use something called navigation. So we take the patient's MRI images and we load it onto a system in the OT, which is like a GPS. So that networks which are mapped on the patient are also mapped on the MRI and it's shown to us on the patient when we are actually operating to see where the networks are. So we can avoid those areas, because if we enter into those areas, if we stray into those networks, we are going to cause impairment in function.
Just taking a step back. So we are talking about opening the head.
Yes.
We are talking about craniotomy first.
Craniotomy.
And how do you do the craniotomy with a saw?
So we have a sophisticated drill system.
I mean, just for layman term, it's basically you just have to cut down the hard skull.
Yes. So what we do is we create something called a hole, a burr hole. So we make a hole in the skull. So the skull actually has bone, which has an outer table, inner table, and in between it has cancellous bone. So we go all through up to the inner table, and there's a covering over the brain. We don't disturb that covering. And then we put the saw. The saw is an L-shaped blade and it cuts only on one side. So we take that saw through the hole and then we cut the bone in the line that we want. And then we join that line to the original hole. So then we get a piece of the bone. That bone is kept aside, it's covered, kept sterile. We open the covering of the brain. And the planning of the craniotomy is done with the navigation. So how big are we making sure we're doing it in the correct place? We're ensuring that we have adequate access to the tumor. Then we open the covering of the brain and we reach the tumor. Many tumors are on the surface of the brain. Some are underneath the surface. So then we have to cut through the brain to get to the tumor. Then again, where to cut, how deep to cut, how to avoid all the important fibers. All that information comes from our preoperative MRI imaging and our navigation. During surgery, we can use various techniques to remove the tumor. Most of the time we use bipolar coagulation, suction. We can use sometimes CUSA, which is ultrasonic aspiration, which is also used in liver surgery. And then we use something called fluorescence. So we inject a dye, and when we inject that dye goes and gets deposited in the tumor. Then during surgery, we can turn on a particular filter in the microscope, which shows us only that dye. So we can make out the difference between normal brain and the tumor.
Tumor localization.
So make sure that we maximize the removal of the tumor. We don't leave anything behind. In addition to all this, there is something known as awake brain surgery. So in certain cases where we are worried about patients' function getting disturbed, so if the tumor is in the speech area or in the motor area, we may decide to keep the patient awake during tumor removal.
So patient is awake during brain surgery?
Yes. That we do only when it's absolutely required, particularly when we're trying to monitor speech. Because speech is one thing that we cannot monitor with any other method. So we can use neuromonitoring, cortical stimulation during normal brain surgery, where the patient is not awake, with some modified anesthetics. But in some cases, we want the patient to be awake. So when we are on the tumor, and we want to make sure that we're not straying into an important area like the speech area or the motor cortex, we will ask the patient to be awake and we'll ask them to be performing certain actions. So if you go to YouTube or Google, you'll find some instances where patients have played the violin during surgery, or some people have sung songs during surgery, recited poetry and so on. Those are all examples of awake brain surgery.
Wow.
Now the reason why that is possible is because the brain itself does not have any pain receptors. So you can cut through the brain, you can dissect the tumor, and the patient will not feel any pain.
Wow, damn. I think based on what you're telling me, it is better to take care of the blood pressure much early rather than bleeding into the brain and getting your opinion on. Wow, amazing. So this is just a side thought, is that no matter how advanced the medical treatment is, right? It is always better not to be in that position.
Yeah, that's true. But I think, when we're talking about gliomas, grade 1, grade 2,
Yes.
grade 3, still the prognosis is quite good.
It's good, correct.
Other tumors like meningiomas,
Correct.
acoustic tumors or vestibular schwannomas, pituitary tumors, the outcomes have been dramatically improved.
Of course. But the same procedure that you'll do for hypertension-induced bleed into the brain, where you're evacuating the clot, pretty much the same concept of
very similar.
craniotomy.
The principles are quite similar.
So, is smoking and alcohol is related to brain tumor by any chance, or probably
Not known. There's no known correlation.
We know that for lung cancer, liver cancer, alcohol and smoking, but it's not that much of a thing in brain cancer. The only thing that we have seen in the movies is that when the hero has a brain cancer, he vomits blood. But that's not true.
Not true.
Not true.
That is more your specialty
My
than
specialty.
mine.
I said that's not because of brain cancer, it's because he drinks alcohol, because he got liver cancer. So, super. So that I just wanted to show my audience that, that's what you do on a day-to-day basis, where you put a hole in the brain and then, deal with all these big diseases in the brain. The other angle that you usually do is spine.
Yes.
In spine related. So the next question is, we talked about red flags of the headache. The most common headache is migraine.
Yes.
So people think, hard migraine, it happens, sometimes in women, it happens during the menstrual period.
Yes.
Around the cyclical migraine.
Correct.
From your experience, is there a factor that we can differentiate, migraine is this pattern, and if it is not following this pattern, please talk to your doctor, something like that?
So there are different types of migraine. There is classical migraine. There is migraine with aura, migraine without aura. Typical migraine headaches will usually be induced by some triggering factor. There are many. If you Google it, and in this case, Google is quite accurate. But stress, certain types of food, like you mentioned, hormonal changes. And usually the headache in migraine occurs on one side of the head. It's a hemicranial headache, throbbing. It's associated with photophobia, intolerance to sounds, what we call sonophobia or photosonophobia, both. And
they can see bright lights.
Yes. They get irritated when they look at bright lights, and they prefer to close the curtains and take a nap. That usually relieves the headache. Caffeine relieves the headache. Many times it's associated with nausea and vomiting. Sometimes they have to induce vomiting to feel better. And that typical pattern of headache is what gets repeated. So if the pattern of headache starts to change, that's when you should get worried. One more very simple test that I do in my clinic to differentiate the red flag headaches from the normal headaches is to look at the fundus of the eye. So the optic disc. So the optic nerve is a very unique part of the body because it's like an extension of the brain.
The nerve supplying the eye.
Yes, the optic nerve, which observes vision. It's like an outgrowth of the brain into the cavity of the eye socket. So if you look at the through the lens, you look at the fundus, which is the head, optic nerve head. If there is raised intracranial pressure, you can see it there. We see what is called papilledema. So in my clinic, when I have a patient with headache, especially if I suspect that something's wrong, I first look at the fundus. And then, of course, if necessary, I send them for an MRI. There's another type of headache I think that we should talk about, which is also becoming quite common. And that is venous hypertension headache. So many, especially common in women, it's called benign intracranial hypertension. So this is sometimes because of oral contraceptive pills, and also sometimes in some other cases where the veins from the brain, which are draining out blood, they get blocked. And that can lead to a severe type of headache, which is very different from migraine. And this type of headache, actually, the pressure inside the head is increased. That's why it's called benign intracranial hypertension. It's benign because there's no tumor. So that's why it's called benign. But it can cause a lot of pressure on the optic nerves and lead to visual problems, so loss of vision also. So this is something that you can only diagnose with an MRI with a MR venogram.
Special technique.
So where the veins of the brain, the venous sinuses are studied, and you look for blockages. And then, of course, you correlate the symptoms with the imaging.
Disease. So in general, we can say that benign headaches, simple headache, without any red flags. No early morning vomiting, nausea,
Blurring of vision.
You could give some more time to see whether it is going away.
Yes.
If not, please get evaluated.
Yes.
And as you said, a good eye exam. Every headache doesn't need an MRI. That's the most important thing.
Correct. We can do it. We can do screening MRIs. They're quite safe. Only thing is the cost involved and the pressure on the system to get more MRIs done.
Of course. Usually, the likelihood of the brain tumors and everything is still, it is getting more diagnosed, but not as common as people think.
So I have I have some patients who come who are very anxious that they have this headache. And they ask me, can you please just do an MRI so that I can, be happy that there's nothing wrong with my head. 9 out of those 10 people will have normal MRIs. Just saying.
We cannot do that in US though. That's a problem. US healthcare system has some good aspects, but mostly bad aspects. For example, you cannot get an antibiotic without a doctor's prescription.
I know.
You cannot get an MRI unless if it is absolutely indicated and all those things.
Correct.
So few of the checkups is actually good. So
I know a lot of people come from the US to India to get an MRI done.
Right, yes.
Probably cheaper to do it flying here, doing it and going back.
Exactly. So, super. So, I think we briefly covered the headache part. So, coming down your expertise, one of the most important thing that you deal with is spine.
Yes.
Okay. And I really want you to explain to our audience in detail regarding the anatomy of the spine. So, what is the cervical spine? And what is the thoracic spine? The C7, T12, lumbar, and the sacrococcygeum. So that they can understand the spine is not a vertical thing like this.
Yeah.
And all these curves, there's a reason there is a curve.
Yeah.
So can you educate us, please?
So the spine is this crucial, very important stack of bones in the back of the body and basically supports the head and the rest of the body lower down. So the cervical spine, basically 7 cervical vertebrae. C1, we have numbered them from C1 to C7. Very unimaginatively numbered, but that's how it is. Then we have thoracic 1 to thoracic 12. And then lumbar 1 to lumbar 5. And then sacrum is one solid piece of bone, 5 vertebrae. And then you have the coccyx. The cervical vertebrae, the first 2 vertebrae are atypical cervical vertebrae. They are not the normal shape and function like the other cervical vertebrae. So C1 is a ring which is attached to the bottom of the skull. And C2 is a vertebrae with a peg that goes through that ring. And this is what enables you to rotate your neck. So that is the C1, C2 joint, which allows that rotation to take place. That's a very important joint because often we get diseases in that C1, C2, very complex diseases and things like atlantoaxial dislocation, basilar invagination, which are difficult to treat sometimes. And they can lead to quite a lot of morbidity and mortality also in some cases. Then we come down the rest of the cervical spine. The cervical spine has a curve facing forwards, which is called a lordosis. Which is similar to what the lumbar spine has. That is important because it maintains the overall balance of the person when they're standing. So we call that, when you look at a person from the side, we call that sagittal balance in the sagittal plane. So if your cervical curve or your lumbar curve or thoracic curve goes out of whack, then your sagittal balance will get disturbed. So you'll tend to fall forward or fall backward. Then you have to compensate by rotating your hips.
I see.
So that to maintain your balance. So it's very important that the lordosis of the cervical and the lumbar spine is maintained as much as possible.
The curve is maintained.
Yes. And thoracic spine has an opposite curve, which is a normal thoracic kyphosis. So thoracic spine starts from T1 and ends at T12. They're very different.
That's your mid-back.
Basically behind the chest.
Behind the chest.
So T1 is very different from T12. T1 resembles mostly the cervical vertebrae. T12 resembles more of the lumbar vertebrae. And the junction between C7 and T1 and T12 and L1 is the transitional zone, the junctional zone. And that's a very important part of the spine. Biomechanically very important because movement is happening at C7 but not at T1. So, the stresses on that segment are different. Now, a lot of the problems in the spine happen because of the discs.
Correct.
So, in between the vertebrae, in the front of the spinal cord, you have these discs, which they're called syndesmosis, is the correct name for them. They're syndesmotic joints. And behind the spinal cord, you have these other joints where one vertebrae is connected to the other by these things called facet joints, which allow some movement of the spine, this movement, bending forward, backwards, and a little bit of rotation also. The thoracic spine is relatively immobile because the ribs are attached to it. So the ribs go around and they go and get attached to the thoracic spine. And let's consider the thoracic spine is relatively immobile and quite stable and fixed because of the external support of the ribs. Then we come to the lumbar spine, which is again a very flexible part of the spine. And unfortunately for us as human beings, the lumbar spine is not well adapted to the upright posture. So the lumbar spine, as you can see, has no support.
There is nothing in the pelvis area.
Nothing. And it's a freestanding part of the spine between the thorax and the pelvis, which are both relatively fixed points. And it ends up becoming a site of a lot of the degeneration that we come across.
That's the most common clinical problem.
Yes. Low back pain.
Low back pain. LBP.
So low back pain is because of the diseases in the lumbar spine. Again, the lumbar vertebrae are much bigger than what you have in the cervical and thoracic. They have these big discs in between them. And fortunately, the good thing about the lumbar spine is the spinal cord ends at L1. So there is no spinal cord in most of the lumbar spine. It's only the nerve roots. But the higher the disease, the more the likelihood of neurological involvement. The problem with the lumbar spine is that when we evolved from four-legged animals and we suddenly became two-legged animals, the lumbar spine did not have enough time to adapt. So therefore, it has become a very weak part of our spinal anatomy and is very prone to disease.
Wow.
So this is why low back pain is such a common problem in human beings.
Wow.
Added to this is the problem that we have become very sedentary. And we don't do anything specifically to strengthen our spines.
So sedentary lifestyle causes low back pain.
Yes, indeed. Inactivity also. And many of the strength training routines, if you look at them, they focus on upper body, lower body. Nobody focuses so much on spine. It's really important in today's day and age, given our current lifestyles, that we have to focus on core and spine strengthening exercises. So the lumbar spine lordosis, the most common problem in the lumbar spine is the lower lumbar spine, because that's where the majority of the body weight is acting. So the last disc in the lumbar spine, L5S1, in some people it's L45, but predominantly L5S1 is highly prone to degeneration, wear and tear, and disease.
Wow. And I believe it or not, while I was big, my waist circumference was like around 102 centimeters. Okay. The first symptom I had, at least one discomfort I had, was low back pain. And when that waist circumference started decreasing, my pain improved significantly.
Yes.
So belly fat is one of the main risk factor for low back pain.
Yeah. So what happens is, because like I mentioned, the lumbar spine does not have any support. The only thing that's supporting the lumbar spine is the muscles, the paraspinal muscles. And when you have a lot of weight in front, it's literally pulling on your spine. And the extra weight is also adding to the loading of the discs. So what we call axial loading. Axial loading means load which goes along the spine, along the axis of the spine. That causes wear and tear of the discs and degeneration, rapid degeneration. So unfortunately now I'm seeing teenagers come to me with lumbar disc disease. Teenagers.
Usually in the past you must have seen around 40-50 years of age then.
So I think the age is becoming
younger.
It's advancing to the wrong direction. We're seeing it in younger and younger people now. Earlier, typically, we used to see it in the 30s and the 40s. Usually somewhere in midlife when you get the first symptoms of back pain.
Correct.
That's happening now a little more early.
So sedentary lifestyle leads to belly fat, which is causing low back pain, which is
physical inactivity, all that adds to it. Smoking is also another risk factor for back pain.
Smoking can cause back pain.
Yes.
Because it is just combined with all the other stuff.
Partly that, also the discs in the lumbar spine have very poor blood supply.
Smoking decreases the blood supply.
Yes. So it causes microangiopathy, blockage of the tiny blood vessels. Diabetes also causes that. So even diabetics have a higher chance of developing spine disease. I've seen it in my practice. I don't know whether it's there in literature. I don't think so. But I do see a lot of diabetics coming with low back pain.
So in diabetes, there is micro deposition of blood clots in the microcapillaries surrounding the kidneys, causing diabetic nephropathy, eyes, diabetic retinopathy, neuropathy. Similar to that can cause low back pain.
Yes.
Fascinating.
Microangiopathy.
So because of all these blood clots, there is decreased blood supply to the brain.
I think blood clots and maybe also accelerated atherosclerosis. In diabetes.
Wow.
Because I think I don't know whether this is right or not. I'm not a physician, but triglyceride transport is impaired in diabetes because of insulin resistance.
Yes. This is something that I'm very aware of. Because, if you look at Indian population, we are not very high in LDL that much.
Triglycerides is the culprit.
It's the triglyceride and the HDL ratio.
Yes.
That's the key. There is, as you know, the multiple research studies says that triglyceride HDL ratio more than 2 increases the risk of heart disease. More than 4 increases the risk of stroke and heart attack. More commonly, if you look at the lipid parameter of any Indian community, most of the times, triglyceride to HDL ratio is more than 4. Because look at the numbers, triglycerides because of the carb diet, it's usually on the higher side. It's 250, 300 sometimes. HDL because of lack of exercise, it's only 30. 200, 300 by 30 is easily more than 4.
Correct.
And what happens is, this is very fascinating as well, that while the triglycerides is high, there is a transmembrane fatty acid reflex is impaired. So it affects the hormone adiponectin.
I see.
Which is right there in the subcutaneous fat. And that is why it's just a recipe for disaster for all the combinations together: belly fat, decreased adiponectin, increased triglycerides, decreased HDL, leading to insulin resistance, leading to hypertension, diabetes. What the patient sees is, oh, my glucose level is high. But there are so many things that needs to happen.
I've made a reel that the disease I fear the most is diabetes.
Of course. It affects everything.
Yeah.
It affects everything.
Yeah.
Wow. That's a wonderful thing. I've never thought about diabetes causing decreased blood supply to the spine, causing low back pain. But that suppose has to be true based on how the disease acts itself. So let's say I had a friend who called me. He's a software engineer, 28-year-old, working in Apple in Cupertino.
Yeah.
And he said that I couldn't get up from my chair.
Yeah.
And he couldn't get out of my chair. It's acute back pain. Tell me why that happens.
So that is usually an annular tear. So if you look at the anatomy of the disc contains 2 parts. In the lumbar disc I'm talking about. And it's there in the cervical disc also. But since we're talking about back pain, low back pain, we'll talk about the lumbar disc. So you have a ring of fibrous tissues, crisscrossing ring like that. Which is holding on to a gel in the center. This ring is called the annulus fibrosus. Nothing to do with suffering or wedding ring. It's a fibrous ring. The gel in the center is called the nucleus pulposus. The nucleus pulposus is basically a gel which gives this springiness to the disc, which allows
the
cushioning. So shock absorption in the spine. So that's what the discs are meant for, to absorb shock. Because you don't want the shock to go to the vertebrae because the vertebrae can get fractured. Microfractures can take place. So you want something soft in between which absorbs the shock. What happens as the discs degenerate is this nucleus pulposus starts getting dried up. We call that disc desiccation. So if you were to look at an MRI, if you look at a disc on an MRI, in the center you'll see a bright white signal on T2 images. And around that, you'll see a black covering. That bright signal is the water inside the nucleus pulposus. And that black thing is the annulus fibrosus.
So you need more white.
You need more white. A white disc with black surrounding it is a healthy disc. So the first sign on MRI that discs are getting damaged is that white signal starts disappearing. That's called a black disc.
So it's similar to osteoarthritis.
Similar.
Where the gel around the knee is getting.
So disc degeneration, first sign is nucleus pulposus gets harder. Less able to absorb shock. The next thing that happens is these annular fibers, because of bending, stretching, poor activity, lifestyle, smoking, these annular fibers start becoming weak and they start separating. So then the nucleus has a chance to come out through them and the annulus tears. And the annulus has a lot of nerve endings. Not blood supply, but it has nerves.
Nerve endings.
And those nerve endings are very sensitive. So when we do surgery also, sometimes we do awake surgery on the spine.
Wow.
Endoscopic surgery.
Wow.
So when we go through the annulus, the patient will scream with pain. Because of the rich nerve endings. So that's what causes acute low back pain in most instances.
Where the herniated disc.
Yes. So the disc comes out, tears the annulus. Annular tear causes severe pain. What happens in response to that? The muscles around the spine go into spasm. To protect the spine from any movement. Because movement will make more of the nucleus come out. So like stop. The nucleus causes that tear and the muscles go into spasm as a protective mechanism, leading to severe pain.
So we need to make sure that the gel is not desiccated or disintegrated.
So you cannot really ensure that all your discs do not degenerate. It's part of the wear and tear. But as long as you keep your discs in place, no annular tears, or if you do have one also very infrequently, you strengthen your back, take care of your paraspinal muscles, avoid bending, lifting weights, sitting for a long time, a lot of bumpy rides on two-wheelers and all.
I see.
It will prevent any disc degeneration.
So these are simple steps that anybody can follow, right?
Yes.
So steps to make sure that the gel is still intact and preventing low back pain is?
So I'll tell you one of my favorite quotations. There are two things human beings are not taught as soon as they come out of the womb. One is how to think and second is how to move. How to think. We all sometimes develop patterns of unhealthy thinking. We catastrophize situations and so many other things, right? We think unhealthy things. Somebody may not mean something, we make it mean something very bad or so that's one thing. All of us need some few sessions of psychotherapy, I think, to get our thinking right and understand what our thinking process is and how we can correct it. Think in healthy ways. Second thing is how to move. Nobody teaches us when something falls down how you should pick it up, how you should carry a heavy weight. We don't learn this. Nobody teaches us. And we all sometimes we look at our elders and our peers and we learn the wrong patterns of movement. And many of these patterns are damaging to our spine. So keeping the weight away from you, reaching for something very far away, not keeping things at a convenient level, at a height, instead keeping things down there, bending in the wrong way. I see a lot of people when they bend, they don't bend at the hips, they bend at the spine. That causes increased pressure on your discs, increases wear and tear.
So when you're lifting let's say you're lifting a cup on the ground, you need to bend your knees first.
Knees first or bend at the hips first.
Hips first.
So these are the things, and then avoiding axial loading of the spine. Where you're jumping, where there's additional pressure. So you're sitting on a two-wheeler and there's bumpy rides. That's going to increase pressure on your spine. Lifting heavy weights, bending in the wrong ways, sitting for a long time. What happens when you sit for a long time? There have been studies where they've put needles into the discs of healthy people and studied intradiscal pressure.
Interesting.
So when you sit for a long time and your posture starts to degrade, you start slouching, then the pressure on your disc starts to increase. You can do it now. If you sit up straight, you'll find your back is very comfortable. But you start doing this, you'll start feeling something happening there. Isn't it?
But this is how most people are.
Yeah, but that's wrong. Because that is what causes disc degeneration. If you keep doing that for hours on end, for years together, I can guarantee you, your MRI will never look normal.
So there is a device in US. I mean, some patient told me that they have the device on the back. It's a Bluetooth device. It's connected to your phone or something.
Yeah. I heard of that, which alerts you to correct your posture.
Once you stoop, it has a small buzzing sound at the back, so you need to come up.
Yeah. But better than that is to time your sitting so that you do not sit for more than 20 or 30 minutes at a stretch.
20 or 30 minutes at a stretch.
So that's why I made us walk when we took a break. So that we stand up and take a break from sitting. I also tell my patients, some of them who are in the IT field, that ask your employers to give you standing desks.
Standing desk.
Simple solutions. You don't need anything very fancy. So keep standing, sitting, alternating. And also to do some muscle activation in your workplace. So you can just lean against a wall, activate your spinal muscles, do some calf pumps. There's a very popular reel that I made called Soleus push-ups.
Right. I saw that.
So those kinds of things will definitely help to maintain your spine health.
Can you show the Soleus push-ups for...
Very simple.
Right.
So you're sitting in a chair. You don't have time to exercise. You're a busy IT employee who's not slept, who's stressed out, high cortisol levels. Keep doing this.
Correct.
As many times as you can when you're sitting. It will do wonders to your metabolism. It will reduce your, it'll improve your glucose control. It'll reduce your triglycerides. It's been shown in studies to do that. University of Houston, I think, had a study on that.
They did that. They improved the insulin resistance.
Yes.
Circulation of the hormones were better. It's the other thing I see is people listen to the video, including me, but the implementation is missing.
Yeah.
So I keep repeatedly saying the same thing again and again and again, so that it gets.
This is a very useful exercise for people who are not able to go out and exercise for whatever reason. No, you're stuck at home, or you're stuck behind a chair or on a wheelchair. If you can still do this, it's great.
There was a number, right? Within a minute, you have to do something.
It was quite a large number. I think in the study, it was for a few hours, maybe 5 hours a day or something.
5 hours together.
So a lot of people got dissuaded by that.
Yes.
But I think at least if you do it 1 hour a day, it's still better than not doing it at all, isn't it?
Of course. So, but all this is indirectly, again, coming back to the same thing of maintaining the posture movement.
Yes.
So posture is always upright as much as possible.
So try to avoid bringing your chin close to your chest because that increases the stress on your cervical spine. So keeping monitors at eye level, for example, not looking at your phone all day like this. And sitting with your shoulders tucked down and your back erect. Try to not take support from the chair, but try to keep your back erect. A lot of people have found value in sitting on a Swiss ball, exercise ball. Because that keeps you active. It keeps your core activated. And because it's moving all the time, you're thinking about it a little more. So I think the modern chair is actually disservice to humanity.
I can compare that to the Western toilet.
Yes.
Same thing. I have seen people actually sitting on that
Swiss ball.
Yeah. Swiss ball. And it's also good because they are not on the camera level. So we don't even know whether they're meeting or not. No, so standing desk is something very popular as well.
And if you're doing strength training, then please incorporate some spine exercises, core exercises. Few of the things that I find very common amongst this population, which is very sedentary, is a lot of them have weak gluteal muscles and very tight hamstrings. That comes about because of disuse of the gluteal muscles. And the tightening of the hamstrings is because of the seated posture.
I see.
And a lot of the movement patterns get affected because of tight hamstrings. So you don't bend at the hips, you bend at the spine because your hamstrings are tight. So stretching out your hamstrings, strengthening your hamstrings, activating your glutes. These are all very important exercises to do.
Most of my friends who want to know about exercise, they come to me. I'm very proud. I don't know why you're coming to me. But I'm learning all this, right? My hamstrings are very tight as well.
Yeah.
Especially exactly the same reason. And then exactly the trainer also said the exact same thing. Where the hamstrings are tight. So my range of movement is extremely limited. So we will put a link in the description to how to stretch your hamstrings. That's what I do on a daily basis for 5-10 minutes. And that really makes a big difference. So the big other problem, the pathophysiology that you explained is the same thing where people say I have herniated disc. And because that gel is herniating out, compressing the nerves, causing the pain.
Yes.
Is that what sciatica is?
So sciatica is a common term. Any pain going down the leg is called sciatica. Whether it's because of a herniated disc or otherwise, the name is sciatica. Now, sciatica can happen because of multiple reasons also. It doesn't always have to be herniated disc. There's something called piriformis syndrome. So the piriformis muscle is in the back of the hip. And that muscle goes across the sciatic nerve. So when that muscle goes into spasm, it can simulate sciatica. I had it once for a few months.
I see.
And it took a long time to get rid of it.
I see.
So that is one more thing. Tumors in the spine can also cause sciatica-like symptoms. But it's important to remember that all herniated discs do not need surgery. In fact, a large number of the patients with herniated disc are managed without any surgery, not even necessary to do an MRI. So when we evaluate the patient, the clinical evaluation is more important to us than the MRI. If the patient has only back pain, which is a symptom of early disc disease, and no sciatica, no pain while walking, and no weakness related to nerve compression or symptoms related to nerve compression, we will not even do an MRI. We'll first treat them with medications, physiotherapy, exercise, and so on. And I will ask them to avoid all those stress factors to the spine.
Weight loss will be a significant treatment option for low back pain, correct?
It is, but
not
easy to do. Not easy to do.
Not
and
at that
I also
time.
have to, not at that time. And also I have to qualify. Nowadays, weight loss means using all these fancy drugs. But there are studies now where people have used GLP-1 and GIP-1 agonists and found that when they use this for weight loss, it actually worsens spine problems because of muscle mass being lost also. So as I told you, muscles are very important support for the lumbar spine. When you lose muscle mass, that support is gone, back problems can increase.
Wow.
So on the one hand, you have weight loss, but you have reduced muscle mass and increase in back problems rather than a decrease.
Wow. In one of the previous podcasts, I interviewed an orthopedic surgeon. And we were talking about why there is no muscle mass, mainly in women. And he was mentioning that he is seeing a lot of hip fractures and including vertebral fractures, mainly in the postmenopausal women where there is no muscle mass. So I was in multiple podcasts as well. I usually say that, as an Indian community, as we discussed, there is decreased protein to start with. On the top of it, we are not having any more strength training, any significant strength training. And on the top of it, we also have a tendency to put a central adiposity with the belly fat accumulation. All this is basically a recipe for disaster in terms of any bone problems, including osteoporosis, osteoarthritis and everything. You see a lot of vertebral fractures patients.
Correct.
Do you see an increased predominance in women as well?
Tremendous. Osteoporosis in the postmenopausal women is a serious problem. Many patients present with severe painful vertebral fractures, many of them requiring surgery, and the surgical options are not that simple in osteoporosis. So if you have to do a fixation, putting titanium implants, the ability of the bone to hold the implant in place becomes a question. So then we have to use special types of screws with cement, and it's not...
So you don't have that muscle to hold.
I think, like we were discussing offline also, it's time that women who are perimenopausal become seriously sensitized to the need to talk about hormone replacement therapy with their primary care practitioners and their gynecologists, and if not, their endocrinologists, because that is the only way that we can obviate many of these problems. A lot of these women, postmenopausal women, have skipped that important period when they should have got hormone replacement therapy, but that ship has sailed, and now they have the effects of postmenopausal loss of estrogen, loss of testosterone, poor muscle mass, osteoporosis. It's devastating. Their quality of life suffers tremendously.
Estrogen helps in bone mass.
Absolutely. Estrogen helps in bone mass, helps in cognition. It helps in sleep. It helps in glucose control. So many things. And it reduces the risk of cardiovascular disease and stroke, which is all something we see in postmenopausal women.
So in menopause, what happens is estrogen goes down significantly. And that's why you're not having any more menstrual periods.
Correct.
Interesting fact about fasting is during the first 14 days of a menstrual cycle, where the estrogen is peak.
Follicular phase.
You can fast like anything, whatever you want. You will not have the cravings. You will not have anything.
Wow.
The fasting period is like wonderful. You could even do like 16 hours, 17 hours, relatively easier. The second half, luteal phase, is where progesterone kicks in, and it's a sugar craving hormone. And that's why many people crave for ultra processed foods and carb rich foods around the menstrual period. Translating the exact same thing into your bone physiology, After menopause, there is no estrogen at all. And if you do not put the effort before, when your estrogen is acting, when you're producing the muscle mass, it's even more difficult to support your bone structure at the later part of time. So what you're talking about is supplementing that estrogen with hormone replacement therapy, where there is an option to increase the availability.
Yeah.
And there was some controversy about, hey, giving estrogen can increase the risk of breast cancer and increase risk of accelerated. There was some study on atherosclerosis. But it is a case-by-case evaluation where you have to discuss this with your primary care.
Yeah, and now there are many options available in terms of hormone replacement. I think from whatever I know, and I'm not an expert in the field, but I think because I see the effects of low estrogen, I'm more concerned that women particularly should be asking these questions and seeking the right answers, because the options available now are plenty. There are not necessity to take oral estrogens only or injectable. There are patches, there are or creams and so on. And there are combinations, estrogen with progesterone. Depends on whether the person has a uterus or doesn't have. History of breast cancer. All that can be taken care of within the setting of hormone replacement therapy.
So I'm going to give you a scenario, okay? So let's say I am a woman between 25 to 45 years of age. Let's say 35 years old.
Okay.
I'm 35 years old. I'm watching Dr. Pal channel and I'm trying to learn all this health techniques and everything. I'm never into significant physical activity before, anything like that. What will be your recommendation to start with? Important
to realize that there's something known as, even bigger than primary prevention, primordial prevention. Basically, anticipate. Nowadays, if you're 35, the average life expectancy is somewhere around 70, 75. You're expected to live another 40 years. If your fitness is at a certain level today, it is only going to get worse from now on, because 40 is usually the time when fitness starts going down if you don't take measures to maintain it. So with fitness, lack of fitness comes all the lifestyle diseases. Your diabetes, hypertension, risk of cancer goes up, osteoporosis, cardiovascular disease, stroke, metabolic disease, fatty liver, obesity, visceral fat, all that stuff. Right? So there's tons of it. You have to understand that you have to be at a certain level today so that your quality of life doesn't suffer in your 70s. And what is that level you need to be at today? So there are a few markers. VO2 max is an important marker. So we know that VO2 max declines with age unless you train it. And we also know that VO2 max, we haven't discussed what VO2 max is. I think we'll have to discuss that. But
so this would be a good point to discuss. So what is VO2 max and why is it important in women?
It's important in all humans, but VO2 max is the amount of oxygen you can consume to perform maximal exercise. So the volume of oxygen, VO2 max. And that is usually expressed in milliliters of oxygen per kg per minute. So your VO2 max, there are graphical tables available which tell you what, according to your age, which percentile you fall in. So it's different for men and women, obviously. But if you are falling in the lowest percentile of your age group, your VO2 max is going to decline by approximately 10 every year. So if you're starting at a VO2 max of 40, which is say in the 50th percentile for a 40-year-old, maybe a 35-year-old, I'm not very sure of the tables, and it declines at 10, by the time you're 70, you're going to be at about 10. And that is not enough for you to perform your activities of daily living when you're 70.
Not even normal.
No, you cannot walk to the toilet. You cannot go to the kitchen and cook your meals. You cannot get onto an aircraft and go visit your grandchildren. So you have to be at 60 now to make sure that you're at 20 when you're 70 so that you can do all that stuff. And VO2 max is the single most important predictor of mortality, all-cause mortality. There are studies from NAGM and I think the New England Journal of Medicine, I think somewhere in the year 2010 or 2000, which showed that VO2 max is the single, just that one number is a predictor of all-cause mortality. Doesn't matter if you have diabetes, renal failure, hypertension, cancer, nothing. just that one number.
Adjusting for all the factors,
Everything.
lower VO2 max, higher mortality.
Higher mortality. So how do you get
How do you
to
increase?
a reasonable... First of all, how do you test your VO2 max and how do you get to a good VO2 max? So these are all questions that are quite nuanced. Testing VO2 max is not easy.
Correct. I did it.
I have done it too, but I think I suffered from lack of test familiarity.
Yeah. It's not easy. They make you run on a treadmill.
With that mask it's very
and
uncomfortable. But yeah, trying to at least get some form of fitness done. And there are other ways of testing VO2 max. So you can, if you can run around a track and you can time the run, there are tables online which can tell you. So you do a 12-minute run test, see how much distance you cover. And based on the distance you cover, it will give you an approximate VO2 max. But I think what is important for that 35-year-old that we were talking about is you have to get into an exercise program. So exercise means cardiac and strength training. So a minimum of 3 days of strength training per week and a minimum of 150 minutes of zone 2 cardiac activity per week. If you can throw in another 15-20 minutes of high intensity workouts, great. On top of that, focus on a wholesome, sustainable, whole food diet. Thirdly, maintain good sleep hygiene and good sleep. And I think try and do whatever you can to reduce stress. Usually exercise will be enough and so will the sleep.
Yeah. Beautiful. Let's say we go into the other end. So let's say I have a 50-year-old female who is in menopause. Unfortunately, did not prioritize her health during 30 to 50. What can she do to prevent osteoporosis and bone-related problems?
So the good news is, as far as fitness is concerned and VO2 max, it's never too late to start. That's something everyone should understand. If you haven't done it all these years, do it now. Tomorrow is the best day to start. So even a small intervention in someone who's totally unfit will definitely have good positive effects. So I think for a postmenopausal woman with osteoporosis, protein intake, strength training are very crucial. And if it's 50 and you're not too far away from the day of your menopause, you must explore the option of hormone replacement as well.
So all this thing we talked about, sleep, exercise, all those things, basically it's a foundation throughout the rest of your life, looks like.
Yeah. So the thing is, people are looking for that magic pill. There is no magic pill. There's all this basic stuff that you do every day that matters the most.
That matters the most. One last thing I want to really touch upon briefly is carpal tunnel syndrome. You have talked about it briefly as well. So even in my colleagues here in US, as you know, we talked about it that we spend more time typing rather than seeing the patients.
Correct.
For documentation and everything. And many people are software engineers, they keep on typing and everything. And when the nerve over here gets trapped, you get numbness, you get pain around your hands. And this tunnel is called the carpal tunnel, and the nerve gets trapped, and that's why the pain and all this happens.
Correct.
How common is that in your practice?
Very common.
Very common.
Also suffer from it. My problem is because of cycling. When I'm holding onto my handlebars like that, then my nerve gets compressed. I get numbness in my fingers. A lot of cyclists also have it. But people who work on computers, keyboards, the tendency is that they rest the wrist on the table or on a mouse pad when they're working. So that usually causes impingement of the nerve. The other time that I see that this impingement of the nerve is a problem is during sleep. So during sleep, many people, the wrist gets bent like this. And that reduces the space for the nerve. And they usually wake up in the middle of the night with numbness and then they have to shake their hands and then they have to go back to sleep. Another thing that one should remember is when it's on both sides, thyroid disease has to be ruled out, particularly hypothyroidism. So many people with hypothyroidism will have both sides carpal tunnel, bilateral carpal tunnel. One thing that I use, and I think a lot of people I've advised them to use, is to use what is called a carpal tunnel splint at night. So when you're sleeping, you wear this splint which is covered, which is tacked down by Velcro straps. That keeps your wrist straight when you're sleeping. You take it off in the morning. It really helps. Other thing is to be conscious of not resting your hand on the table when you're typing, keeping your elbows, so you have to have strong shoulders for that. And you have to make sure you're not doing that.
Correct.
Which will increase your neck pain and
Correct.
your shoulder pain.
The recipe for disaster is sitting in front of the computer like this with the shoulders down, stooping down, and then with the thing. Everything is going to get affected.
Yeah.
So straight, standing desk, upright, front. Okay, I'm going to order a standing desk.
Also, I think you should explore voice to text.
Voice to text.
Yeah. So that you don't have to type. It's really a game changer.
Yes. I use that on my phone.
Yeah. So it's really useful.
It has trouble in finding my accent. I say it's okay.
It usually learns.
It learns.
Some machine learning may be happening
Yes,
there.
yes. With ChatGPT around, you never know what's going to happen. True. Beautiful, beautiful. Super. I'm going to wrap the session. By being a neurosurgeon, you are seeing all this brain and spine related problems. One thing that you can tell the audience for spine related injuries to prevent, to focus on from today so that they can learn from today's discussion, what will that be?
3 things, if you don't mind me saying
Of
3.
course.
If you are in a sedentary job, please see a good physiotherapist so that you can get your posture checked. Second, be aware of your posture all the time, especially when you're working, especially when you're mentally occupied. What I tell my patients is set an alarm on your phone. So every half an hour, that thing will go off and it will remind you to take care of your posture. And third thing is please, please, please work on strengthening your spine. That's the only way that you can continue to work uninterrupted without any spinal issues for the rest of your life.
Spinal strengthening includes weightlifting and resistance training.
Yes, but under supervision.
Under supervision.
Yeah. So glute strengthening, hamstring stretching, spinal extension, core muscle exercises, planks, mountain climbers, all those sort of things.
And some people believe that when they have belly fat, they think that only if they do core, it'll go. They keep doing, include me, they do this abdominal crunch.
Those crunches are to be completely avoided.
Avoided.
Yeah, because that if
both
you don't
this crunch and also this crunch.
If you have poor muscles in your back and you do those crunches, you're going to build up a lot of good abdominal strength, but you're going to also likely injure your back. So you can do modifications. So your physiotherapist can guide you about what are the right modifications. If you've had a history of back pain, then the exercises will be different.
So spot reduction of a belly fat should be spotless. Should be
Belly fat has got nothing to do with your abdominal muscles.
Muscle.
It's all to do with the fat in the belly. So you have to work on reducing belly fat. Visceral fat, as you know, and I'm sure some of your audience members also know, is the most damaging type of fat in the body. Highly pro-inflammatory, linked to all the lifestyle diseases that we can think of.
One important point, I think it's a good thing you raised that. If you think that abdominal crunches help the belly fat, make sure that you're straining your back muscle as well. So for belly fat reduction, I'm going to tell you right now, it's body fat redistribution. If you don't understand what I'm talking about, please go and watch my 100-day Gutman challenge. Every day from day 1 to day 100, it was painful to shoot. Okay. But in addition to the good work that you're doing in the clinical world, you're also doing great work in the charity world as well, where you are a back surgeon giving it back to the community. I want you to explain that to my audience.
So in 2014, I started this charity initiative, which is funded by the trust that my parents started.
Nice.
And we call it Giving Back. The reason is because I myself had a spine issue. And then I realized, being on the opposite side of the table, how it felt. And at the same time, what happened is I realized a lot of people coming to me who were breadwinners for the family, fairly young, middle-aged people on whom their families depended for daily earning. But because of their spinal disability and issues and pain, they were not able to do their work. And their families were suffering. At the same time, they were not able to afford treatment in private hospitals. And at the same time, they were not able to get treatment in the public sector hospitals because of the long waiting list.
Wow.
No fault of anyone, but that's how it was. And I thought, how can I make a difference to this situation? So we decided that we will fund this. So we started funding it through my cycling friends. So I had a friend who was taking part in this race called the Tour of Nilgiris, which is a 7-day race taken through south of India.
I see.
And I took part in that in 2009 and then in 2011. And then one of my friends took part in it. And he said, I want to do something for your hospital and charity. So he said he'll raise funds for giving back. And that's how it started.
Wow.
And the first year, we barely raised about 50,000 rupees and we did about 10 surgeries.
Nice.
But since then, it has grown. My younger brother has ridden the Tour of Nilgiris. I have ridden the Tour of Nilgiris. My friends have ridden the Tour of Nilgiris. As part of this giving back initiative, we organize sporting events in Bangalore for people to take part and contribute towards the cause.
Nice.
And using these funds, I think we've raised more than 30 lakhs in the last 10 years.
Wow.
And we've done about almost 500 surgeries.
Wow. Wow, that's goosebumps. Good.
So the reason I wanted to bring this about, and we've actually grown over the years, the reason I wanted to do this is because I wanted people to experience the best quality spine care that's possible, irrespective of cost. I don't think any human being should get inferior quality care just because they cannot afford it.
Strong statement. Yeah. So my audience, I know I have a lot of audience in Bangalore. Okay. So you're going to support this campaign, not for him, for you, because I want you to do cycling.
Or running. Both options are available. Duathlon. Once a year.
Yeah. So we're going to put that in the description. Please check that out. Giving back fundraising campaign organized by Dark AB. Super. Thank you so much for your time. It was wonderful, wonderful meeting you.
I think we could have gone on for a few more hours, but unfortunately we have to end.
These guys will kick us out. But anyways, wonderful. Looking forward to work with you in future as well. Thank you.
Pleasure was all mine. Thank you.